Hello, bonjour. Good afternoon, everyone. And once again, my name is Chad Mitchell. I'm with Alberta Health, Alberta Government. And I'm pleased to be here today, and my apologies with a scheduling conflict that's pulling me away last minute here. But I absolutely love this agenda. So by training, my background is as a pharmacist, but I also have a research degree in health outcomes. So I was pleased to hear all the conversation today, and I was chomping at the bit and realizing I don't have much time on the podium here, but I have so much to say. So I'm going to try to keep my comments brief. So the title of our session is not such sunny ways for those writing the checks. So what do those checks look like? Here's some numbers, and this is from with my ministry, Alberta Health. And these are just expenditures for my community-based drug programs. So these are programs for low-income individuals, seniors drug programs, and we do have a drug plan available for all Albertans. They have to sign up for it, pay a premium, and there's co-pays that they do pay out of pocket. This doesn't include our expenditures for oncology type of products or what we call specialized high-cost drugs, which includes transplant drugs, HIVs, and items like that. In our fiscal 16-17 year, we spent about $1.5 billion, and that's an increase of 4.7% on those expenditures for drugs. That is for drugs. That doesn't include our costing for distribution fees, since some of these drugs are complex and require certain handling. It doesn't include dispensing fees, and it doesn't include our pharmacy services. So in Alberta, we do pay pharmacists for certain assessments and activities. Of the drug expenditures, about our top 5% of patients, our expenditures are, or about 37% of those expenditures on the top 5% of patients. As we take a look at where we've been creating some headrooms, generic drugs is one of a hot topic these days. About 73% of our claims are for generic drugs, and that represents about 34% of our total expenditures. On average, underneath all our three different drug programs there, we spend about $1,400 per patient per year. However, if we take a look at individuals who are on the biologic drugs, our annual spend is around $19,000 per patient per year for the group of individuals. And there's about 3 drugs in that class that's driving about 85% of our biologic spend. So what do these numbers mean? What are some of the challenges that we're looking at? High-cost drugs, we are noticing that the mix and volume of high-cost drugs is shifting. So as new innovation therapies come along, we are seeing the cost per patient going up in there. Generic drug savings, as I pointed out, about 70-some% of our claims are in generic drugs. There's a lot of conversation about how much Canada pays for generic drug pricing. We're still higher than the international average, but we've taken steps to reduce those pricing. So the high-yielding opportunities for us to get savings on further generic price reductions is limited. We're seeing increased utilization. So what I'm seeing in Alberta is we used to have a relatively young population, but aging probably the quickest amongst the provinces and territories. So on any given day, we forecast about 70 new seniors coming onto our drug plan. Also, our current fiscal scenario has seen an increase in enrollment for our low-income drug programs. You don't have to go far. You can open up the paper, the ministry business reports, to see some of our fiscal pressures and how we're being budgeted. So as we take a look at our drug expenditures are going up about 4.7% from the previous fiscal year. We're forecasting that when you add in all those different pharmacy fees, pharmacy services, things like that, that our growth rate will be in the 12-13% growth rate. As a ministry or as government, our budget is around 2.7% growth that they're factoring in. So you can see that we have to pull from other sectors within education and other ministries in order to make sure that we have a sustainable drug plan. And also we have to take a look at different mechanisms in which we can create more headroom for our drug plans so that we can invest in new innovative therapies. So our challenges, how can publicly funded drug plans continue to offer a broad range of clinically effective, valued type of medicines, while also promoting long-term sustainability without compromising patient care? So that's one of the challenges that we're bringing. And how do we create headroom? About 2 years ago at a CADA symposium, if people were in one of my talks, I used the word disinvestment. It turned out to be a dirty word at the time. I'm going to clarify a little bit about that because disinvestment means a lot of things. But what we're trying to do is how can we work together to accommodate this continued innovation? How can we disinvest, and I'll explain more what disinvestment means to me in this space. We realize that these decisions impacts patients, but also impacts other stakeholders and sectors. So for instance, health professionals, they're used for certain clinical practice, certain practices out there, and it's disruptive if we start making formulary changes. We're also seeing what I call convergent effects. So as new innovative products come on the market, we also see pressures in other sectors such as laboratory, diagnostic type of environments there. And also, how do we build off of guidelines and evidence reviews and incorporate this into practice? So one of the answers I always say, the number 17, and those of you may be familiar with what the question is how long typically does it take for research to make it into frontline clinical practice in 17 years. So how can we cut down on that gap with each new innovation that comes onto the market so that we effectively and efficiently use medications? So the dirty word, disinvestment. There's a lot of different terminologies out there. I like to say that we're disinvesting to actually reinvest into our drug plans, into our healthcare system. It's more than just taking a drug off the formulary. Disinvestment also includes, restricting use of medications where the best evidence is for certain population groups. It means working on pricing. So we've seen successes with the Pan-Canadian Pharmaceutical Alliance and reducing our expenditures on medications. And we also realize that we need to incorporate evidence and take a look at how we're using drugs that are currently on our list. The difficulty that we have is once you start providing a benefit, it's hard to change the criteria or to take that benefit away. So how can we work with stakeholders on disinvesting if it does mean changing criteria or actually taking a drug off the list? In Alberta, we also have what we call a ROBS process. And I put a little picture of a robber up on the podium because a lot of people think that we're just robbing from the listing there. But it's called Review of Benefit Status. And it's actually in our formulary book, we outline the process and the steps that we take as we review the medications that we do currently provide. And some of the outcomes of these reviews haven't necessarily been taking drugs off the list. One thing that we've done is a review of inhalers used for COPD. And we take a look at how we are listing certain medications in a class. And in some cases, it meant less restrictions for certain inhalers. We've also announced policies on proton pump inhibitors to take a look at, do we need to be paying such a difference in prices for some of these PPIs when we have some evidence from areas such as CADA and that they're equally effective. So these have been some of the disinvestment approaches that we have. Appropriate drug use. If you go on the Canadian Institute of Health Information, and they have a lovely dashboard on potentially inappropriate use of medications, and it plots it out by various provinces. And if you take a look at Alberta, Alberta has slightly higher than the national average of potentially inappropriate prescribing. Why is that? If I have a broader scope of practice for pharmacy services, if we have different processes in place, such as our strategic clinical networks that look like clinical practices, what's some of the drivers behind there? And also, if you go online, our Pharmacists Association runs what we call the Envirix program, and they take a look at disposing dead drugs. In 2014, they reported about 71 metric tons of unused medications being used. Why is that? Is there things that we can do to make sure that as people get their medications, using it appropriately, have the right amount of medication in their possession? So instead of not sunny, I think there is sunny ways ahead, and this is what excites me. Like, how can we start creating more headspace and a thoughtful disinvestment so that there is that opportunities for that reinvestment in new, innovative, clinically effective drugs, and how do we broaden that patient access to existing drugs? So I'm switching my title from Not So Sunny Ways to Sunny Ways Ahead. So looking ahead. How do we take public values, patient input, and to make sure that we have the right considerations in there? And in the last session that we had upstairs there, that was one of my questions, is I really want to understand what does success look like for meaningful patient impact or input as we take a look at some of the decisions we have to make? And that was one of the things I posed to my colleagues around in the room. So with that, I'm going to conclude my presentation. I'm going to hand it off to my colleague, and we'll have some Q&As afterwards.
Thank you, and thank you for the invitation. It's a privilege to be here with you this afternoon, and it would be a quick visit because I'll have to go with my new best friend this afternoon. I'm also a pharmacist. I've worked in hospital for more than 20 years, and I know as well as I can know the network around surrounded in Quebec. So maybe there's some people here who do not know what INES is and exactly what it does in the environment. So our mission is to promote the clinical excellence and the efficient use of resources in the health and social services sector. We are for the Quebec what CADET is for the rest of Canada. So when you heard about CADET today and probably tomorrow, don't forget that there's an INES in Quebec. And if my president, CEO was here this afternoon, he would say that all the money that are involved in the different updated process that are ongoing in Canada, Health Canada, CADET, PMPRB, probably is at 25% funded by income tax from Quebec. So INES play in the arena of technologies, medications, and interventions that are used in health and social services. We are a team of about 200 persons by now, and our team is constituted of different specialization of our professional who works with us, and we work with different external experts in all of our evaluation. We inform principally the ministry, the healthcare network caregivers, and also the clinicians. So we do a lot of work for medication in the arena of optimal use. So we do a lot of tools for clinicians to support the optimal use. We inform how by mobilizing different actors about knowledges and different considerations, social, ethical, and political one. And we, pardon me, I think I go too fast. How do we do that? We are interested in the knowledge transfer, and our evaluations are constituted by the scientific data, the contextual, and also the experimental context. So we have to introduce all those aspects in our process of HTA. And we do that around a definition of value who is determined by health outcomes and costs throughout the continuum of care. So it's a dynamic process, and we want to be sure that we are not far away from what is going on in the environment. And we also know that the value has a different phase according to the different perspectives, so that the doctors has their view and the patients has their one. So we want to mix those perspectives to do the better recommendations. And for sure, the patient is in the center of all this process. Last May, QUEBEC has launched a life sciences strategy with different selected targets, and especially for drugs, it demands us to be more synchronized in time for the listing of our recommendation with those from CADET, just to permit our minister to be seated at the same table as all the provinces in Canada to negotiate, particularly with the PCPA. So we are, to respond to that demand, we are in a continuous mode process changing. So by the beginning of the next year, we will be fully in a continuous process to accept the submission from the manufacturers for the drugs evaluation, and we will change all our process to be more adapted to this new reality. The strategy has us also to begin to do at least 5 pre-NOC evaluation, and to reduce the time between the delivery of the notice of compliance by Health Canada and the reimbursement by the Quebec government. So we'll be linked to listing and probably also to some different strategy that manufacturers and industry will propose to the government. So this strategy is there to make a faster access to the promising drugs. So the goal is a better coordination between CADET and HINIS, and also to prioritize the real innovations that are coming in the market. The manufacturers in Quebec want to have an advantage, so it has different meanings, and it will be sustained by different discussion between the government and the industry. We'll also have to be more filled with dollars. So we are on a fees implementation process that is in the file for the government consideration by now, and we hope that it will be implemented in the next year. And we also have, related to those fees, to publish a declaration of services by the end of the financial year, next financial year. So globally, the context of drugs in Quebec, there's that strategy that is in place. The adherence to the Pan-Canadian Pharmaceutical Alliance has allowed us to change the way we proceed in our evaluation, and also in the arguments that we give to the governments to be seated at the table and to have the best price in Canada, and especially for Quebec. We do not write the checks, but we hope to be an helpful and by this in this action. In the last year, RAMQ has published the economy they have done with all the negotiation, and with all the changes that are going on in Health Canada, PMPRB, CADET, there will probably be some more changes that will be have to be implemented just to be in mirror with the attended in this strategy. And now the new dynamics that we are implemented in Quebec to respond to this. So don't forget that Health Canada gives notice of compliance, so the right to commercialize a drug in Canada, based particularly on the evaluation of efficacy and security of the drug. INIS, just like CADET, we do recommendations to the minister based on an added value. So on the previous panel, there was a girl who explained the difference in the HTA process than the actions the Health Canada do. And finally, the minister takes decisions, and the RAMQ in Quebec implement those decisions. The act of INIS is almost is precise. The role we have to play in the environment in Quebec. So we do recommendations with a view to updating the different list of drugs, the reimbursement context. And we have to first assess the therapeutic value for those drugs. So sometimes you see differences in the recommendations made by CADET and the one that are made by INIS. And we, at our knowledge, we are the only jurisdiction who have to have a judgment on the therapeutic value first before we go on evaluation for the different other aspects. This evaluation process is based on evidence, so we want to see what the literature says, and it's those data are adjusted to the Quebec's context, and the patient's needs and preferences are an important aspect to be introduced in our evaluation process, and then to the decision to the recommendations we'll do to the minister. The ability to pay is an important aspect that we take account in our process. In addition to clinical, economical, and ethical listing, the experience lighting of the patients is added in our process. The quality of life is an important aspect too, so the patients are the more I'm a French Canadian, are the most well placed to give us those information. We have implemented a new questionnaire for patients and one for Patients Association. We have different methods to look for the information that you can give us to better do our job. And those questionnaires take informations about sometimes association and directly for the patient. We want to have a declaration of conflicts of interest, and we are aware about informations, the impact of the disease, and the experience you have with the previous treatments, and the needs and your preference about those treatments. Rapidly, we are going to update our framework, and one of the things we want to implement is a multi-criteria decision analysis process. So, with the 5 aspects that are precise in our act, we will have 6 criteria for our scientific committee to deliberate around all the process. So the importance of the health needs and how the drug generate a clinical benefit in regard of those needs. The medication efficiency, so the economic and pharmacoeconomic aspects, the importance of the benefits for the population, and the capacity of the system to offer the drug, so that's directly in the subject of this symposium, and the organizational capacity to afford the drug. Don't forget that the deliberative process is a quantitative and also a qualitative judgment. So this also can explain some differences in the recommendations from CADET and from INIS. And finally, what is the innovation in medication? So we see in the Pan-Canadian Pharmaceutical Alliance with all the negotiations that the risk-sharing agreement are greatly in part of the agreement, but there's also development of evidence with real-world data, and it's a big question for us how we will evaluate those data. How we will use those data to probably re-evaluate the indications for some drugs and probably give some more arguments to the PCPA to renegotiate the drugs. So, thank you.
So thank you very much, Chad and Sylvie, for very interesting presentations. What we're going to do now is open it up for a few questions, and I did want to hand it over to the patient representatives. I think they have a few comments to make, and then we'll open it up for some quick Q&A as well.
Every slide I see highlights biologics when we're talking about cost, and I just wondered sometimes. You know, we've been saying in our community that that years ago, I guess, we should have had more registries that actually measure the outcomes of what we've saved by giving patients these medications. Since the very beginning, patients have been part of the criteria for access to biologics. Most patients start on the older drugs, if not all patients should start on the older drugs, and only when they're not responsive to those drugs do they move on to access to a biologic. And I'm interested to find out that someday maybe we'll know what the cost savings have been to the system by giving somebody a biologic instead of having it as always the highest cost drug we spend money on.
Just very brief comment on the disinvestment that Chad brought up. What made me think is that sometimes drugs that are on formularies, they work for patients and they shouldn't be taken off just because they're old or because not a lot of patients use them. So I think we should look more at the question of sequencing. When should drugs be given to patients? And what are the desired outcome that we're looking for? So, you know, that way maybe it's not about doing the evaluation of the newer drugs, but also looking at the evaluation of the older drugs and making sure they're still there for patients who need it, who need them.
So thank you very much for your questions. In regards to RA and biologics, you know, I want to wave the Alberta flag We had a group of rheumatologists earlier on when infliximab was released on the market, and they did put together a biologics registry to monitor individuals. So these were our academic clinicians, and it was quite a robust database at the time that allowed us to take a look at that. Now, in terms of the savings, I don't want to say a number because I can't remember exactly the savings that they forecasted in the reports, but I think that's an area where we can connect in to show you know, some of the work that has been done in real-world evidence and an approach to it. So I appreciate that comment. I think there's some follow-up that we can do just to show that we have been looking at that space, biologics in particular in RA in Alberta. On disinvestment, I agree. It's not necessarily should a drug be taken off the list. That's the hardest decision to make and also to implement. But what are the other ways that we can take a look to make sure drugs are used effectively and appropriately? And as I mentioned before, you know, Alberta does have higher than the national average of potentially inappropriate prescribing. So is there other things that we can do? One of the panelists before on the first session mentioned about the strategic clinical networks. So one of the ways that you can do that is take a look at the clinical pathways and what you're calling sequencing. But not only on the treatment, on the drug treatment, but other things that we can do. Is there non-pharmacological methods, things like that? How do we make sure that patients are seeing the right person at the right time, getting the right therapy at the right time too? So I agree, disinvestment meaning taking drugs off the list. That's a hard decision. It's hard to take away, but are there other ways that we can take a look at how they're appropriately used?
It's maybe that they shouldn't be prescribed in the first place because they're the wrong drug for the patient.
Sylvie, est-ce que vous aviez une réponse ou un commentaire en réponse aux questions ou ça va?
No, that's okay.
Okay. We'll take maybe one or two questions from the floor if there are any. Okay. So 1, 2.
Merci beaucoup, c'était très intéressant. Sylvie described how the patients are engaged in the HTA process for INES. And Chad, can you comment on the patient engagement piece for your HTA assessments for your province?
So we rely upon CADA to collect that patient feedback as a drug goes through the HTA process there. We do have an open door policy to meet with different patient groups, and I often do ask, and from time to time the answer does look different. What additional information should I know that maybe look different than your patient's submission? So that's what I am interested in hearing, particularly if there's an Alberta context around that. Does Alberta have a formal patient submission process? No, you're correct. We don't have anything on the books, but we are interested in, yeah. But we are interested in hearing from patients, and especially on that Alberta context. It's about also getting the information at the right time. So as it goes through the CDR process and all that, and as it's hitting the Canadian Pharmaceutical Alliance, is there anything in the Alberta context that we should know as we approach to sit down with the companies or our PCPA colleagues and come up with sort of an action plan on how we're going to approach a particular drug?
Right, or if you were like disinvesting in a drug, you wouldn't have a CADA report to work from. You wouldn't have that, you know, that patient submission that you can rely on, or if it was clinician initiated, for example, from Alberta, in that case, would you do something to engage the patient?
Yeah, and what's nice about these strategic clinical networks is they do have access to these family caregivers. I'm using the long terminology groups as part of the health system that Alberta Health Services, our regional health authority, has set up. So there's also that opportunity too for that collection of patient feedback.
Merci. Sylvie, j'adore travailler avec toi. C'est pas la question, mais je me devais de poser une question. As a matter of fact, if we're spending quarter of the amount required for CADET, for PMB, MRE, and so on, what is the added value of the INES in all of this process?
I won't give a politic response. I don't think that there will be a merge between our different organizations in Canada. You probably have heard about our Minister for Health and Social Services in Quebec. So the orientation is so clear that INES is there for stay, and we have to compose with this in Canadian environment. We want and we have to be more synchronized with our different works, not in the matter we study or we evaluate drugs, but in the time frame. That's what is asked to us in the life sciences strategy. And we exchange a lot with CADET. We talk to each other. And we have more and more discussion with Health Canada in the updated process that they are going on. So we are grounded with this Canadian environment, but the reality of Quebec is that.
And I love that we have, I would say, a more precise approach toward Quebec environment and legislation. I think that a part of it should be also implemented in the other jurisdictions so that they are contextualizing the report from CADET. But it was just, I was just wishing to know what will happen.
And what we heard about the contribution of INES, and probably my right colleague will talk about this a little bit, is that now that Quebec has adhered to the Pan-Canadian Alliance, Pharmaceutical Alliance, they have two recommendations. They have two completed evaluation, and they have different arguments that are evaluated and put in tension. So it helps. Probably it complicated a little bit their process, but they have the different views of those evaluations.
Well, being the last speaker of the afternoon, there's probably not much new to say. My name is Kim Kirchley, and I'm the Deputy Minister of Health for Prince Edward Island. I am a nurse, but I've spent most of my career in academia as a clinician and as a researcher. And so as a clinician and as an academic and as a researcher, I'm very, very pro world evidence, real world evidence, outcome measurement, value-based decisions. But I will add one other element to that, and that would be ethics. And I think it's important when we're doing any consideration around patient care that we're giving ethical considerations as well. And so I haven't heard that mentioned today, so I will throw that out. I was asked, I did ask myself why I was asked to come and speak. And I'm humbled by the quality of the speakers. I'm absolutely respectful of the patient opinions and their suggestions. And I've learned a lot today, and I'm really very pleased that I did come. But it occurred to me mid-morning, being a civil servant and coming from a small province that probably has the most work to do around formulary. And so what I've learned today I can certainly take back. But PEI does have the lowest numbers of drugs listed on a provincial formulary. We have a small population. So if you want to set the context around healthcare in general in Canada, when the Canadian healthcare system was designed, 50% of the funding came from the federal government and 50% came from provinces. And now, provinces are receiving as little as 18% from federal government. So that puts extreme pressures on provinces and territories, and particularly pressure on small provinces that have a low population, that economically are not at par with other parts of Canada. So Prince Edward Island depends mostly on seasonal employment, part-time employment. Often there aren't the healthcare benefits that they would have with longer-term employment. And so as a result, we don't have the large tax base that we perhaps could have in a better economic climate. So I'm not, I'm just saying that just so that you have a good understanding of what we face in Prince Edward Island. So some of the current pressures that I've seen during my role as Deputy Minister, which is less than 18 months, and I was told on my first day of employment that the average life of a Deputy Minister was 18 months, so it's coming up fast. And I will add in there that my own Minister of Health prays daily for a cabinet shuffle. And he openly states that this is not easy. I mean, health is so complex and nobody is ever happy. So oncology medications we're extremely vulnerable right now. There have been a significant number of new medications added that are terribly expensive. And we can't keep pace. And so I will say openly that we have the fewest number of oncology drugs listed on our formulary. Next to us is Newfoundland, and they have twice as many oncology drugs. And so there's a real social justice issue there that does not sit well with me, that just because you live in a different province, you do not have equal access to healthcare services. The medications for rare and genetic conditions, certainly that's been mentioned enough today, so I don't need to dwell on that, but they are an extraordinary cost, and they are lifelong, and so a huge cost to the system. The treatment of opioids is certainly another factor that's contributed, which is different, I think, than years ago. And so, you know, methadone treatments, Suboxone, they're daily treatments, and so therefore the dispensing is daily. And another factor that wasn't mentioned today, and that is the cost of dispensing fees. And I think it really does need to be mentioned. So of our drug budget, 46% of that budget is spent on dispensing fees. And I mean, that is just not right. And then, of course, the new opioid crisis that is nationwide. We do not have a crisis in PEI, but we are obligated to ensure that we have naloxone treatment on hand, and so there is an added cost. On PEI, there are 29 drug programs. So my question was, why do we have 29 drug programs? People don't know where to go, they don't know how to access, they don't know which one is best for them, and they really just get lost in the system. The reason why we have 29 drug programs is because drug programs were developed as new medications came on board or as new clusters of diseases were formed. And it absolutely makes no sense. Not only do we have 29 different drug programs, but the cost of the drugs within that program can be different depending on what plan. There is income testing in some, and even the income testing within those is different depending on what disease you have. And so if you did have rheumatoid arthritis, you may be tested, your income testing may be different than if you had cystic fibrosis. And there is, and I will say openly, there is absolutely no rhyme nor reason why this is the case. It just is the way it is. So we have a seniors drug program that was developed in the 1970s, and it was developed because many seniors at that time had been farmers and fishermen, and they did not have drug programs. And so it was expected that they would receive, after they turned 65, they would receive their drugs free of cost. That tradition has continued, and now PEI, we have 24% of our population is seniors, but many of them are retired seniors that have chosen PEI as a retirement destination. The landscape of seniors' income is much different, and yet we do not income test for seniors. So in an effort to modernize the system, and the thought was we should do universal income testing across the board so that everyone is treated equally and fairly. And the money that we then recoup from those who can pay, and that was mentioned earlier, those that can pay should pay, that we could then reinvest in the pharmacare program. And it was it Wayne this morning that said, you know, everybody wants you to change the healthcare system until you, it was Fred, until you actually implement a change. I mean, I was in the priorities policy committee room with ministers, and it went over like a lead balloon. They could not do it. And their response to me is, we can see the people that we knock on doors and canvass to vote for us. We can see what conditions they have. We can see what effect this would have, and they absolutely could not do it. Regionally, we're looking to see, okay, is there some common threads that regionally, as in Atlantic provinces, that we could move forward on in order to see equity and equal distribution. And then nationally, of course, in the ministers' meetings in Edmonton in October, the decision was made that we would continue to look to have a national formulary. But as Louise said this morning, it can't be the lowest common denominator. So the national formulary can't be what it is in PEI because it would not suit the needs of the other provinces. So there are some good practices in PEI and some of the best practices, and just a couple of examples really quickly. The catastrophic drug program was probably one of the best drug programs to be developed in 2013 because it does do income testing, and this is really very important for families who do have conditions of rare diseases. And so they are income tested based on their household income, but there is a threshold. And so once they've met the threshold, there's no further cost. And so we're not making people poor from paying from their drugs. The generic drug program was also a very important drug program that came in 2015, and there was a lot of work done in this area. And this was developed for the people in PEI who did not have third payer insurance. And it's estimated that about 30% of islanders do not have a third payer provider. And so with the generic drug program, and more drugs were added to the generic formulary, the maximum that would be paid would be $19.95 for a 3-month prescription. And so since that has been developed, 18,620 people have enrolled into the generic drug program, and it shows that there was definitely a need for that program. The hepatitis C elimination strategy was talked about this morning, and so Prince Edward Island actually negotiated outside of the PCPA, sorry. And it really was, it was done to meet a real need. And so the decision was made to treat hepatitis C patients regardless of the extent of their liver disease. And I know the word cure was used this morning. I'm a bit hesitant to use that. I'd like to say that they were absolutely treated. Patients can be reinfected, and so they can develop the disease again. But what I really admire about this program is that it came with education and counseling along with the drug program, which is so important because of that lifestyle modification needs to be addressed. There has been significant efforts, and we heard that from PCPA, to lower drug costing in generics and in brand drugs. And there is discussions ongoing about a universal drug plan. The challenges are really is about the fiscal capacity. We have a healthcare system now that is heavily focused on acute care, which is very costly. There is very limited resources to look at any sort of wellness promotion activities. For example, in PEI, we know that the #1 risk factor that could be eliminated, that would target the big diseases such as cancer, heart disease, stroke, and lung disease, would be to stop smoking. And it would cost us $1 million to implement a smoking cessation program. But recouping $1 million out of a health budget that is always over is very difficult. And so we continue to dump money into the care system with very little left over for upstream initiatives. And so it's a competing demand for funds. And so today in PEI, the legislature opened yesterday, and so we're announcing the expansion of diabetic strips, the covering of diabetic strips testing for women with gestational diabetes. And that is absolutely the right thing to do, right? To get babies off on the right start. And we'll announce that, and it should be a good news story, but there will be many other people that have other conditions saying, why didn't you do something for me? And so it's that outcry, that reactionary, that emotion that makes it very, very difficult. So the future directions and some of the issues that we're planning to look at are perhaps looking at some biosimilars, which would, I think, again, we would need to negotiate outside of PCPA, but I think we really need to go there. The thing about the rare disease, which makes it so difficult, is because they're rare diseases, there's not a lot of research done because most people don't have those diseases. And so trying to make decisions around treatment of rare diseases with drugs that do not have strong evidence is very difficult. Income testing, we'll take another run at it, I think. But really, to me, it's the balance of treatment with prevention, trying to get early intervention or even prevent people from becoming ill is the key. And I was listening to Terry when she spoke about her 19-year-old niece who went with high blood pressure and cholesterol, and I thought, good for her to have the knowledge to know that she could do something differently. But there was a part of me thinking, why does a 19-year-old young woman who's active have hypertension and high cholesterol? How did she get to that point? And so it's getting into those school-age kids about lifestyle and diet and so forth. So it's complex. There's no easy solutions, and I don't pretend really to have any of them. But I think what's most important and what I'm struck by today is that we're all partners in this, and there shouldn't be us versus them, that it really has to be the pharmacies, the drug companies, government, public, patients, all working together to come up with the best solutions. So, thank you.
Thank you very much. Thanks for 2 wonderful presentations. I'll let the patient respondents make some comments and questions.
First of all, I want to thank you for coming here. You're incredibly brave. I wouldn't want your job. But saying that, the PCPA, I guess some of the issues we've had with the transparency of decision making and patient engagement into the process, and I realize there's challenges with that as well. Again, if you can come together on pricing, you need to start coming together on coverage. I know it's a challenge for some of the smaller provinces. I'm from New Brunswick, so I do get to PEI fairly often, and we have similar challenges in our province. I think as a country we need to try to start addressing some of those challenges, and for the betterment of all of people that live in our country.
Just a comment or question, and first for Anshali, thank you very much for your presentation. And I'm really heartened to see that you're increasing the number of listing agreements where you're looking at evidence-based generation, real-world evidence. And my question is, why can't we find out what those are, and where are they listed? Because I think patient organizations have a very large interest in making sure that this happens for every, or potentially every products, every therapeutic area, especially in cancer, because nobody, or any disease for that matter, nobody wants to take a drug if it's not working. So, I mean, I know there's question of transparencies with the manufacturers, and I mean, why does it have to be non-transparent? Maybe the price or the cost that's paid, but the scheme itself, I cannot understand why. It doesn't make sense to me.
Thank you for the. It is on. Thank you for the question. And you kind of answered some of it as well, in terms of a lot of the times it is the manufacturer that binds us to the confidentiality portions. All of our jurisdictions have said they would prefer to not have any of the confidentiality. It's easier in terms of product listing agreements as well. On whether we could just publish the types of agreements, the way that the UK's PASLU does. We've even come into issues with that as well. So we've had manufacturers' legal teams on our cases because we've said the type of agreement, not any of the confidential terms of it. And even when it's not specifically a real-world evidence type of agreement, there were some terms in there that had something to do with the amount of products that clinicians were giving out, and we were specifically instructed that we could not let clinicians know that portion in case it skewed how they would be prescribing, which would affect the confidential rebate that PEI got. So it is a really difficult and challenging one. It's one that we'd have to discuss with manufacturers in terms of, do they have a comfort level of being able to share what type of agreement, not the confidential deals. But that's why it was in one of my last slides, in terms of, if we are doing a lot more real-world evidence agreements, can we actually make the fact that we have a real-world evidence agreement a public notice, so that we can collaborate with clinicians and patient groups on it. But there does need to be a lot more conversation with the manufacturers on their comfort level of that.
I would argue that it's really critical to have the patient's involvement, because that's what real evidence is about. It's about the evidence for patients and how the drug really works for them. So I think that would be important.
I agree.
Yes. Thank you very much for coming. I agree. It's the first time I've actually had a presentation or heard about the PEI healthcare system, and I can just imagine what the challenges you would have based on, your population and the cost of some of these drugs. So I would assume that for your islanders, having a national formulary would probably be a good thing for them.
Yeah, if there was a national formulary, absolutely, it would give the direction that we need to be at par with the rest of Canada. And I will say that New Brunswick just last year implemented universal income testing in their province, and it went over extremely well. And the announcement was, there will be some winners and some losers, but this is the fairest way to prescribe or to cost drugs. And so we looked at them, actually, and they did a great job of that.
Right, thank you. So we have, we'll take 3 questions.
Thanks very much, and I agree, Kim. I think that your coming here is wonderful. It's really the first presentation I've heard, and I've been around since the dinosaurs, where I really felt there was a real person talking to real people, not a politician talking to real people.
I didn't know I was brave until today.
Well, we'll definitely give you a plaque saying that. I have a question for each of you. Initially, everybody who's talked to us today, including our first panel, has talked about the importance of real-world evidence as part of our evidence generation. But everybody seems to be doing it, going back to my problem of silos from first thing this morning, everybody seems to be doing it in silos. And I'm very worried. Well, first of all, it seems to me inefficient and cost ineffective. But in addition to that, I'm afraid everybody's going to collect something different, and then we're never going to be able to really put them all together and ask questions of this, what could be a profoundly rich, source of information. So is there some talk amongst all the different agencies about the possibility, imagine, of one sort of repository for real-world evidence? So that's my question for you. And I really would love to hear a little bit more about how you think, because I keep trying to figure it out in my head and I can't, how we would really create a universal, I don't like pharmacare, so I call it universal drug coverage. I mean, I don't mean I dislike it, I don't like the term, because everybody has a different definition for it, I think. But how would you see that kind of thing like rolling out? I keep thinking, who's going to pay for it? Your province doesn't have a lot of money to begin with. Is the idea that other provinces would be willing to give you some money? I'd love to see that day. And how does that all work? How would that ever work? I mean, I'm not against it. I just don't know how we'd ever do it.
I can start. I think along with, it's not just about the number of drugs that are on the formulary. That's part of it. But it's the way that citizens pay for those drugs. And I really believe that there has to be rules of engagement that are common across provinces. So Ontario have just announced that they have universal health care for children up to 18. But most provinces can't do that. There's absolutely no way. And so that puts the rest of us in an unfortunate situation. And so if there was ever a way that each province could come up with just the ground rules of how to approach a universal Medicare or medicine coverage, I think that would really help. So if someone in PEI moved to New Brunswick, then they were treated the same way. And if they moved to Nova Scotia, it's not very Canadian that you're advantaged or disadvantaged depending on what province you live in. That's I think, the biggest thing.
And Louise, in terms of the data collection being siloed, we recognize that. We recognize that there are some jurisdictions that have much more rich data sources than others. But it's not just about the abundance of data as well. It's, are they collecting the correct kind of data and the data that can actually be used? So there has been a lot of discussions amongst all the participating jurisdictions about how we can use the data collection sources that we have right now, how we can build upon it and improve, and how we can make it more national to be able to help with our negotiations. So we are looking at it and how to consolidate it and better use it and build it.
Okay, I have just a fact check, one for each of you. 46% of drug budget goes to dispensing fees?
We have, I was just talking to Chad, we have the highest, because he told me he was in pharmacy negotiations, and I said, yeah, we're in pharmacy non-negotiations. We have the highest dispensing free in the country, and Alberta have the second highest. I mean, it's absolutely ludicrous. I don't know how it happened, but it has to be addressed. And so try negotiating to take something away. It's absolutely impossible. So, true fact.
Thank you. You had made a comment about biosimilars that you would, you had made a comment about biosimilars that you would have to go outside of the Pan-Canadian Pharmaceutical Alliance negotiation. So, question to you, biosimilars aren't part of your mandate?
They are, yes. It's something that PCPA is looking at, and we're looking at it with all jurisdictions as well. So PEI is part of those discussions as well. So yes, I'd be quite interested to know more.
Well, it's just saying that we wouldn't wait for PCPA's approval or adoption of the biosimilars. We would go ahead of the other provinces. And I don't. No, and I won't say it. No, it's okay.
Okay, and we'll take a last question or comment here.
Thanks. I just need to clarify something. I was just doing a bit of quick reading on the approval processes and to the point where PCPA gets involved in negotiations. And it said that, okay, first of all, Health Canada does the approval. Then CADITH does its thing. And if CADITH approves it, then the PCPA begins price negotiations. And I just want to confirm that, is that generally the way it works?
So the quick kind of flow chart of it is once a product has Health Canada approval, once they have their notice of compliance and a drug identification number, then they go into the HTA process, the health technology assessment. So that's INES, CADITH, CDR for non-oncology, PCODA for oncology drugs. And once there's a final recommendation issued by the HTA bodies, then it comes to PCPA for negotiations prior to listing on the public drug plan.
Okay, so within the CADITH or the HTA approval process, cost is a part of the formula.
So
if you haven't negotiated a price yet, how do you reconcile the?
So when CADITH looks at drug products, they are looking at cost effectiveness of a list price of comparators and the list price of the product that's in question. Within PCPA, we know the confidential prices of the comparators, and sometimes that is different to, it needs to be perhaps a lower price than what CADITH is saying, but CADITH and INES are very valuable resources to us to give us a kind of a starting point of looking at the cost effectiveness as well as the clinical effectiveness of the drug to help in our negotiations. And we had heard about kind of INES bringing another layer onto that, and there was the acknowledgement that sometimes it brings challenges, but sometimes it's also very good to have a look at INES's recommendation as well as CADITH, because INES looks at the budget impact within their specific population, so that's more helpful information for negotiations.
So you're not concerned that there would ever be a CADITH decision or an HTA decision that would disqualify a drug based on the fact that the final prices haven't been established?
So they don't usually tell us what the final price should be. Sometimes it's just an indication of significant price reduction. So the list price, it's managed by the Patented Medicines Pricing Review Board, so PMPRB, but that's kind of on the list price, so it's not excessive. But in terms of the price that the PCPA negotiates, it's the price, the confidential price that jurisdictions would pay. If the HTA recommendation is a do not list, the PCPA generally doesn't negotiate or list the products. And on recommendations where they do recommend reimbursement, it usually is conditional, and one of those conditionals is a price reduction.
Okay, so it's just the fact that I don't know what the markup is on these and what the relevance of list price is, et cetera, it just leaves me wondering when there's a threshold, that any drug with a quality cost of this much isn't going to be accepted. Are we getting into a point where negotiations could have provided a different decision?
Yeah, and it does take the cost effectiveness into consideration, but mainly the approvals is on the clinical effectiveness of the drug. So if the cost effectiveness is the issue, then that's within the recommendation of, yes, this drug is clinically effective, but we would recommend, if you're listing, that there's a significant price reduction.
Thank you, and we'll take one last.
This is probably really unfair to ask, but
would either of you want to talk a little bit about CAPCA and how it's now been part of the process? I'm from the melanoma world, where that's had a huge effect on our patients getting treatment in this country. So, I mean, is that, something, you could maybe talk to a little bit?
Sure. I mean, I know that CAPCA has had their consultations with patient groups as well on CDIAC, how it actually works with PCPA. Is it increasing the timelines to getting access to drugs? And the short answer is that it's not adding on any timelines. It's happening at the same time as PCPA. This discussion was happening even before they were formalized as CDIAC. So one of the recommendations that comes out of PCODA is that jurisdictions get together and decide how you're going to implement this as a nation. And that's what CDIAC is actually doing. We don't wait for CDIAC as we're concluding our negotiations with the manufacturer. The same thing with CDIAC. They don't wait for us to start before they do their work. We have been working very closely with them in terms of helping the timelines to merge better, because it does help to know how the product is going to be implemented. But in terms of having them on our process guidelines flowchart, which many of you have seen and been part of the consultation, we are in discussions of working that in to better explain how it fits into the PCPA negotiations process.
I just need to make a comment now. Kim, you and I have had this conversation not that long ago. It comes back to transparency, and I haven't seen anybody in the room from CAPCA, and it's still a huge concern for a lot of us out there. And I mean, I don't want that to be the topic for the end of the day, but I think that's something, Kim, my meeting with you was fantastic in your presentation here. You're speaking to us like a real person, and we truly appreciate that. But I think, there's still other issues that need to be addressed, and the best people we've started the conversation amongst us as advocates, but we really need to continue the conversation, because there is some gaps. We think, we don't know, because we don't see them, so we don't know what they are. Just for the record, for the room, CAPCA is the Association of Cancer Agencies across Canada. Some of you may not work in the cancer field. And I just need to put it on the record that I invited CAPCA, I assure you, to come. I invited both the executive director and the head of the Cancer Care Ontario, who's also heading up this secret committee, and neither of them were willing to come and talk to us. So I don't want you to think that they weren't invited into the room. In fact, they were the only stakeholder we invited, even the private insurers, and they know how upset we are with some of their rules. They're even willing to come and talk to us. And CAPCA, not on your life. So I think that's a worry. When there's no transparency, there's no due process, secrecy makes us very suspicious. And in the year 2017, almost 2018, every other group at least is transparent with us, and at least there's due process in speaking to patients, and this group doesn't do that. And I know neither of you is responsible for CAPCA, so I'm not blaming you, but it really is terribly distressing in this day and age when we talk about patient-centered care, that there's actually such an important, powerful group that makes life and death decisions, or recommendations at least, that are being followed, and they don't even want to come in the room and talk to us about it. I think that's a big problem for Canadians.
So on that note, thank you very much for being in the room with us and for these wonderful presentations. Thank you.